Tamzin is a senior lecturer at Imperial College in London and a consultant at the Homerton Hospital, where, as we've heard in the last session, she's an expert in and leads the AAN and high-resolution anoscopy service. Tamzin is the current chair of the Royal College of Surgeons Women in Surgery Group and co-founded the Working Party on Sexual Misconduct in Surgery. Tamzin, therefore, can I invite you to give this year's BJS Lecture, Happy Workforce, Better Surgery.
So thank you very much, and I'm sorry for people who were in the session before that you've seen so much of me, and I promise I'll shut up after this for the rest of the conference. Happy Workforce, Better Lives was the title I was actually given. And I see that it's turned to Happy Workforce, Better Surgery, but essentially we're faced with the same issue here. I just want to thank you, Martin, but also thank Jared and the ACBGBI, and particularly the BJS for inviting me, and I'll mention the BJS later on and the role they've played. But what I want to say is that the happy workforce, why do we have this title? And you wouldn't be having this title if we had a happy workforce. At the moment, essentially, the process with the workforce is a bit of a shit show. We're in the middle of an actual doctor strike. We're in the middle of quite a dismal general election. All the main party leaders are men, and indeed, Fiona is the only woman in that. We even have some of the smaller party leaders are men. And the happy workforce, better lives, there's something a little bit kind of easy in this, and it's the sort of thing that you get on trust websites, isn't it? It's all kind of aspirational, but what does it actually mean? And in fact, all of those little titles there were from trusts that require improvement, and a quarter of trusts require improvement, but that doesn't stop them having very aspirational comments on their websites about their meanings, which is great. But is all this pie in the sky? What are we actually talking about? Better surgery, how are we going to get that? How are we going to get better lives? And whose lives are we talking about? So we have to do a bit of excavation in order to work out how these things are going to progress and how can we move this all forwards. Why am I here? Why did I start in this era? And it was sort of 8 years ago, I was involved in this video which went viral on the internet of these kids. And we spent the morning with them drawing surgeons and firefighters, and then they were fairly shocked to find that's what we were. And then I ended up being part of the ACPGBI's task force on equality, diversity, inclusivity, along with some of my co-authors here. And you may remember back in 2021, we essentially did a focus group, all on Zoom, through 19 of the 20 ACPGBI chapters. And the people who joined that focus group, quite a lot of people, a vast majority of people who chose to join that had at least one protected characteristic, and explained some of the problems that they were experiencing in colorectal surgery in Great Britain and Ireland. I'm going to put that here. I can't get it to move forward. There it is. Okay. So Dina Haji examined the themes from this. It was anonymous, but these same themes kept coming out. And these will be familiar, but it's also the reason why we can't let go of this concept of equality and diversity, because there are some people whose lives are extremely unhappy while working with us as our colleagues. There's a lack of support and a lack of role models for people from certain groups, and particularly a lack of mentors. In the yellow, you can see that unconscious behaviours were brought out, and this is where microaggressions, unconscious bias, and undermining came in. People are describing the psychological consequences of experiencing this all the time, that they had to have a subservient role in order to just to do their job, and the impact of this sort of behaviour on them. And then, we're all bystanders. We all watch this going on. What we don't object to, we are complicit in. There are people who were essentially explaining the lack of inclusivity. And when you think about the meritocracy that we use and that we think we are applying to everybody fairly, this is the difference between equality and equity. We don't all start from the same starting point. And when we're all judged by the same finishing point, that is where, we think by giving everyone an equal access to that finishing point, that we're being fair, and it is not when people start from different backgrounds. If you can have sort of different A-level results, depending on what school you go to get into medical school, then we can apply the same principles of equity to people who are already facing so many barriers to sort of equal assessment, both when it comes to those barriers to progress in surgery and also to exams. And institutional accountability. So within the ACP-GBI, that's us. So at the moment, not a happy workforce. Then we had Kennedy. So the Kennedy report at the Royal College of Surgeons, which exposed a lot of these problems in 2021, and was the thing that inspired me to stand to be the chair of women in surgery at the Royal College of Surgeons of England. And then we had Becky Fisher and Simon Fleming's article in the Bulletin, which really sort of opened our eyes as to what's going on in terms of sexual misconduct within surgery. So this isn't only colorectal surgery. These are some quotations from the report that we put out about this, and just exposes some of the problems that people have, which is that this supervisor probably had no idea that the person who was receiving these approaches had that dread about going to work. And that's someone who has to do their normal job, but also manage the dread. And this is reported, and everyone who gave the qualitative comments gave permission for us to use these. But this is someone who is literally being spoken to in the corridor after a failed investigation, and it's one of the reasons why people don't report. So we did form the Working Party in sexual misconduct, and it was a multidisciplinary group with a lot of surgeons, and inspired by my colleagues Carrie Newlands and Daljit Darawal, who are both maxillofacial surgeons. And this is where the BJS came in, because it's actually really brave of them to publish this. We had a number of alternative places that were not keen on publishing it, but the BJS went with it and had a huge, as you may remember from September last year, there was huge media interest, 35,000 downloads, and a significant, in fact, crashed the website on that first day. And also that was the report that we brought out. And this is the finding that sort of made it to the mainstream papers. 30% of women surgeons in the study, so in the 1,400 plus people who completed the survey, reported having been targeted with sexual assault, compared to 1 in 15 men. And this is the statistically significant difference between men and women. About 50% of the survey respondents were men, both on that figure of being the target. And if you think about it, this is why we subtitled it, Men and Women Are Living Different Realities. So if you are a man, and it hasn't maybe occurred to you that you walk into theatre and every day someone is commenting on your behaviour, commenting on your appearance in a sexually discriminatory way, this is something you have to deal with, as well as thinking about the patient and performing the surgery. And there's also a difference in witnessing. So women are more likely to have witnessed this, more likely to have witnessed assault as well. And so unless these episodes are only happening when witnesses are female, maybe there's a difference in perception as to what this actually consists of. And men are more likely to underestimate harassment and even assault. And I've just put this picture back up in case you didn't spot where the hand of the man is. It can be very subtle and difficult to spot. And this is why there's this sort of aid memoir. So if someone reports to you, or if you yourself are targeted or a witness, you want to try and classify this behaviour into these categories. Was it just a careless comment? Is this person actually being creepy? Is this concerning? or is it actually criminal? And the way we respond has to be along those lines. And that gets me just to think a little bit of work with our psychology colleagues about the perpetrators. So we know that when this is reported, there is a denial, as in that quotation at the beginning, victim blaming, cognitive reconstruction. But when you think about the characteristics of the perpetrators themselves, narcissistic, difficulty with empathy, intelligent and highly functioning but not picking up on these clues, does this remind you of anyone you know? And it is true that a lot of us actually know the people who are carrying out this behaviour, and we know who they are. There is potential impact for interaction with patients, and we'll go on to dysfunctional teams. But also, she's like, how do people live with themselves? And one of the ways that Ross Searle has discovered is that there's a sort of moral bargaining. You think, well, I cure cancer in my day job, so it's okay if sometimes the rest of my behaviour is not quite up to scratch. And the Surviving Scrubs website, they also published a report this year, just describing these sort of categories of how this kind of behaviour leads to essentially an unhappy workforce. So women being belittled and undermined, the impact on survivors, people living for decades. We found in this sort of Me Too moment, there were people coming out with stories things that are still affecting their working lives 10 years later. Men as victims as well, but a culture of tolerance, all of us allowing this to happen, and just how powerful perpetrators are. So in our report, we produced some recommendations, and I want to think a little bit about where we've got to since then. So for a start, we asked for a national implementation panel, and the Working Party is now part of the Gender Pay Gap Group, which reports to the Health and Social Care Select Committee, so we've at least started on that one. What about policies and codes of conduct? We're working on the independent investigations, but in fact there's been a lot of work, and we've been advising on it with sexual safety policies, and every healthcare organisation needs to have one, but hopefully there will be a template soon released by NHS England and the Royal College of Surgeons that we can base that on. What about a code of conduct? We don't have one at the ACP, but there are other organisations that have one, and we should easily be able to acquire that. The main problem will be what to do when people break those rules and how to respond to it. And then the NHS Charter, which the ACP has signed up to. Education-wise, we haven't really agreed on where we can get to with education, but we have got an undertaking from the medical schools that they're going to ask when students go out into placements that they have the same protections as employees. And a culture and performance of accountable organisations was another sort of recommendation group, and we've started to work on some of those with the help of the GMC and NHS England. So the GMC, Good Medical Practice, now has some questions on sexual misconduct. You may have seen them in the GMC trainee question as well, and the NHS staff survey also has some questions this year, and 26,000 staff reported unwanted behaviour from colleagues in that. So we're starting to get some data that will serve as a baseline. We've also spoken to the CQC. I spoke to the Women and Equality Select Committee. Politicians have paid attention, and we're starting to see that impact on policy. But there's a lot more to do. We need to make some impact on what happens when things get as far as the medical tribunal service. And a lot of the sort of LGBTQI and ethnicity data couldn't come out in our survey. It would have started drilling down too much to preserve the anonymity. But we know that if you have protected characteristics, the more you have, the more likely you are to be targeted by this sort of behaviour. And there needs to be, so there's a lot more work that needs to be done. So while I was sort of drilling around looking for happiness quotes, I found a lot of toe-curling stuff, but I thought this one is actually true. And this is written by someone in the 1930s, before the introduction of the word microaggression. But this is exactly what it is, that it wears away at your self-confidence and your happiness. So I interviewed someone about this talk, and this is someone working in a surgical team who feels unhappy because he's reached the limit of where he's got to in his profession, and feels that he is stagnant and didn't have the right training. and I'm talking about a PA. I know it's a really hot topic at the moment. You can see with that middle advert, they've had to withdraw that erroneously, this IMG referring to physician assistants as physicians. And certainly there's a lot of concern about the planned expansion of PAs into our surgical teams without regulation. There's also the problem of pay. I asked this PA, you know, how do you cope? You're being paid so much more than the doctors who are supervising you. And he said, it's the market rate. And it just shows how we've allowed junior doctors to be paid less than the market rate, and that's why it's such an issue. We're not going to get a happy working team, we're not going to get a happy workforce without resolving these issues. What about SAS doctors? In the Kennedy report, casual discrimination, belittling and humiliation. And it happens more to our SAS colleagues, many of whom are international medical graduates who also spoke to us on our focus groups. So much work has been done in this field across the board, so the Academy of Medical Colleges, the Edinburgh College, and Vanita Shekhar, who's speaking later today, produced this fantastic SAS strategy with the rest of her team at the College of England. And it's really worth a read. If you are an SAS doctor, or if you work with SAS doctors, which is all of us, SAS surgeons can now become college tutors, regional directors, can have access to all courses at the college and to pump ironing grants for research. And so are no longer to be in that position, as the PA said, of having a limit to the top of where their career ambitions can go. And that is absolutely right, and what we need in order to bring our colleagues into the surgical team with us. And we've already mentioned trainees and pay, but I think essentially what we need for trainees is respect. I don't think that I had that as a trainee. I was belittled. Even when I was 40, I was being spoken to and told off like a child. You know, when we're in ARCPs, when we're interacting with trainees, these are our future consultant colleagues. That's how we have to speak to people right from the beginning. And ARCP should be formative. It involves actually a complete change in mindset. There are other things we need to do to try and improve training. And you know, in this day and age, to have the sort of differential attainment that was, this is from the Kennedy report, is absolutely unacceptable. I can't go into all the ways that we can think about improving these things, but this has been already being introduced in Wales, and it's been introduced in Northern Ireland, which is single employer. Now, those are small countries, and whether this can work in England needs to be worked on still. But the potential is that it would cover a few hospitals and a few years of training. You wouldn't have to keep registering, keep doing mandatory training, and it would reduce the risk of having to travel vast distances while keeping your family in one place. All of this is about not only pay, but also working conditions. And burnout is a problem. If you look at this, the number of core trainees in the current census from Royal College of Surgeons who are considering leaving surgery is 40 to 48%, and there's no statistical difference between men and women in this, and burnout is being cited. It's also there when you ask people whether they would recommend their specialty. You know, this is all of us. We need to make sure that everyone working with us, and also ourselves, that we find a way of trying to improve the conditions for people. Because some of these things, some of the comments are actually improvable. It doesn't involve the BMA and negotiations. Feeling like a glorified admin assistant and having to run the same cycle of gaining trust before being allowed to operate. We've got to find ways to try and improve this so that people can acquire those skills quicker, shorten training. And consultants, we still have the problem of disproportionate GMC referrals by ethnicity, saying that the GMC have recognised this and are actively working on reducing this. And in the census, we're also working near burnout levels. So 67% of people are always or frequently working over hours. And in fact, if you look at the number of SPAs, less than 2, not taking their full holiday allowance, and this actually quite significant rise in people working over 11 PAs in the last decade, we're also heading into this same problem. And you can see here that the number of PAs on a gender breakdown is actually the same, but we still have a gender pay gap, and that is just NHS pay. So why is that? There's probably, we know that there's an ethnicity pay gap as well, but we don't have the breakdown in the figures for that. So here's another of these sort of happiness quotes. This is from Thich Nhat Hanh. Freedom is the only condition for happiness. And I think that is, in order to try and get our happy workforce, everyone needs to have that feeling of freedom and autonomy. And we need to have some hope when we're thinking about the future. I feel nostalgic for this era when we were feeling hopeful about Obama. So back to the BJS, this recent publication, 710,000 operations, and it showed that if you have diversity, gender diversity in the team, both the anaesthetists and the surgeons, then you can reduce the risk of major complications. So they only looked at major surgery by 3%. Now, it doesn't sound like very much, but that equates to 22,000 people with fewer major morbidities like return to theatre, anastomotic leak, and death. And how are we doing in the UK on this front? You can see here that in that proportion of operations that happened in a team where the surgeons and the anaesthetists were over 35%, that it reduced the risk of the major morbidity. The deputies of our politicians have gone up from 0%, from the leaders, to 50%. And so how are we doing with surgeons? Consultants, that's the 35%. So there isn't a single specialty in this country in surgery where we are currently a third women. So we're not over requiring to work for equality and diversity. But when you look at registrars, in fact, we're already there in general surgery and in lots of other specialties, we're already over a third. So as has happened with the politics, the deputies are coming up and there's going to be more diversity, we hope. It's the same here. But deputies don't often turn into the leaders. They remain in that deputy role. We need to make sure our female registrars make it through to consultant level and that we stop the leaky pipeline. One of those, we're looking at the outcome in terms of better lives and better surgery. Civility Saves Lives is a really interesting campaign. They've been working just looking at the impact of rude surgeons. I'm sure you don't know any rude surgeons, but this is looking at anaesthetic performance. There's also evidence that it impacts on surgical performance. And the interesting thing about this is that the anaesthetists themselves did not report any difference in their performance. So they were unaware of the drop in their performance when dealing with the rude surgeon. Luckily, this was simulated. But actually, these were both observational studies which showed that functional teams lead to better surgery. So the risk of complications and death goes up with poor team behaviour, and complications go up with more reported unprofessional behaviour. So if we have a functional team, we should have a happy workforce. Poorly functional team, I don't know if this will make you think of anywhere you've worked, but a lack of trust, a fear of conflict, and a lack of commitment. This is actually based on Silicon Valley, but applies to surgery as well. So we need to work towards having a highly functioning team with a clear commitment to our shared task and a unanimous focus on results. How can you yourself respond if you are the target or you witness poor behaviour? And if you've done any active bystander training, you're probably aware of the 5 Ds. Particularly if you are in a junior position, then deflecting is probably the safest, but you can also document, and you can delegate upwards, so you can speak to someone you trust in a position of responsibility. Again, if you're able to, you can challenge with a direct intervention. It's quite hard to do. One thing you can ask is just ask someone to repeat what they've just said, because then it focuses everyone on listening, or ask them to explain why something is funny. Another thing which was told to me by Annie Hanninger, an anaesthetist, is the CUS framework. So you can just respond by saying, I'm concerned by what you've just said. This is making me uncomfortable. This is unsafe. And then you can just say stop. What should the ACP be doing? Regarding sexual misconduct, ACP has signed up to the NHS Charter. We need to get a code of conduct. We need to promote women. No more men-only panels, which I think has been achieved this year. You won't be popular with this one, but limit alcohol at events. It actually reduces the number of incidences, as was shown by the nurses, in fact, and provide active bystander training. And as you know, the maxillofacial surgeons have been active in this space, and they have a code of conduct. I'm speaking at their conference next week, and I was sent this, and it also says what the consequences are if you step over the line and are deemed to do that. So we can literally just take it and rewrite it for the ACP. We've also signed up to do this by July. That's today. We've got to provide support. I've got to communicate standards of behaviour, and we have to have policies, training, and reporting mechanisms. So we need to know where the ACP has got with fulfilling these charter pledges. I searched for a code of conduct on the ACP website, had no hits. I looked for equality, diversity, and inclusion, and I've got our equality statement, but that came out a few years ago. There's no real evidence that a lot of work is happening. There needs to be energy and enthusiasm behind this. So I had a look on the BOEM's website, and they have a beautiful list of things with dates, with times, and then little case studies of people. So we need to have it, we need to basically be embracing equality and diversity, and we also need to understand just how that will make a difference to our outcomes and to our workforce, as well as it being the right thing to do. So diversity initiatives are still needed. It behoves all of us with privilege. We've all got our own areas of privilege, not to be blind to that, and to work as allies. In that way, that's how we're going to create happy teams, better lives for everyone, and better surgery. Ultimately, what we want is better lives for patients. And I'll leave you with this final little nugget from my happiness search on the internet. Growth itself contains the germ of happiness. Thank you. Thank you very much. Cheers.